Hello, everybody. I just want to say thank you all for coming out. We're all very excited to have you here. Today we welcome Dr. Robert Hammond. Dr. Hammond is a clinical psychologist in the VA system, and he is also Chief of Behavioral Health for the Army National Guard in Ohio. Let's give him a warm welcome.
Good afternoon. If I had PowerPoint, I probably couldn't do much with it right now anyway, because my hands are frozen from coming outside. But so I'm glad to see a pretty good turnout here today. Typically, you never know what kind of an audience you're going to get when it comes to talking about anything actually related to psychology. So I thought what we could do today is try to keep this pretty informal. There's sort of the structured part that I can do, go over a few things, and then open it up maybe for some questions, that sort of thing. I find that a lot of times I've been doing this stuff for so long that the things that I think are pretty obvious, a lot of folks, they have questions. If I stop along the way and I start to use acronyms that I just sort of gotten used to, please feel free to stop me, and we can go back and circle around. So. I came in today basically to want to talk a little bit about military psychology, also talking about working with veterans. It's sort of an area that's near and dear to my heart for a lot of reasons. A big one being obviously that having been a soldier myself, just really see it as an opportunity to work with folks that have a lot of conditions that, quite frankly, in society today, we don't always hit the mark in terms of treatment. So I know a lot of you are, sort of in different places in your careers. Some may be looking at going on in psychology, maybe social work, maybe in some other areas. So there's a lot of different ways that you can help out people in this population that we're talking about. So just by a show of hands in here, is pretty much everybody here a psychology major? So, okay. So, regardless of what you end up doing, I always tell folks, psychology is sort of like one of those, it's sort of like a souped up liberal arts degree that whether you go on and you become, more involved in the clinical treatment, or if you end up using it for other things, you really can't go wrong. There's just so many areas where you can use it. I've seen people apply these things in business. I've seen them applied in other places, as well as obviously clinical treatment. So, if anyone tells you, hey, psychology, what are you going to do with that? Well, you can feel pretty rest assured that there's a lot of good opportunities out there. So, a little bit about myself. Personally, I hadn't necessarily thought of directly going into the military. Early on in my career, I actually had become a psychologist. It's going back many, many decades now. And at the time, I had family members who had been in the military. And, it seemed like, a nice option and everything, but I had actually become a psychologist before I had gotten into the military. So, when an opportunity came up, like a lot of folks early in my career, I was just trying to figure out what to do, trying to figure out how to make a little extra money, that sort of thing. And I had some friends who had been in the military, and I thought, okay, well, maybe that's a way to serve. Sort of the interesting thing about the way my career went with that then is, I went to a recruiter, wasn't really sure what to expect. I didn't even know really what psychologists did for the military, for the most part. And pretty much today, as I'm talking about this, I say military, most of my experience is going to be around the Army. Every military branch is a little bit different, so each one has its own nuance. But there's a lot of overlap, obviously I'm not going to know every detail about other branches of military service, but typically we can get you the answer if you got a question about it. So I go to this recruiter, they're like, hey, cool, psychologists, we need psychologists. So they stick me in this unit, and it's what I didn't know at the time was it was a PSYOP unit, and everyone's kind of like, well, what's a PSYOP unit? Well, it actually has very little to do with psychology when you think about it. I mean, it does, but from their perspective, they weren't looking at me saying, oh, this is going to be a clinician that we can use. Literally, it is an area, if you go back in history, you look some of the wars, you see, the people that dropped the leaflets, are trying to change the hearts and minds of, the enemy, so to speak. So, and over time, it's evolved to be a much more complex type of science. So I got pulled right into the middle of using psychology in much more, kind of like what you would think of like what we do more in social psychology. It was there to study populations, to see what they were thinking, how we could avoid conflict in certain situations, which seems like kind of you don't hear people talk about in the military much how we can avoid conflict, but that's exactly what I ended up doing, for a big part of my military career up front. So I got into this group, the PSYOP group. We really started looking at how do you change population behaviors. So, and at first it was all pretty much about theory because it was peacetime, wasn't in a deployment situation. To back up a little bit, this is about 2001 when all of this was going on. So I joined up in 2001, and if in the back of your mind you're thinking, oh, how patriotic, this guy joined in 2001, probably right after 9/11. No, I can't admit to anything that cool. I actually joined in like March, and then kind of had sort of that oh crap moment right around September, trying to figure out, well, what's this going to mean? And it actually did end up meaning a lot in terms of, really changing the trajectory of things. So whereas a lot of it was at first a lot about theory, very quickly we're ramping up efforts, in wartime situations. So in the course of my career now, which is it's pretty much going on 18 years now. This degree has taken me literally around the world. I've now been deployed 3 times. With that first time that I went, absolutely interesting situations to look at, not only in terms of just being a psychologist and looking at human behavior altogether, but actually the act of actually going through a deployment really taught me a lot about how, a lot of things that go on with veterans. You might think to yourself, okay, so when we talk about veterans, what are we usually talking about? So what kind of disorders we usually talk about when we're talking about veterans? PTSD. That's almost immediately the first thing that comes to mind when folks are thinking about wartime efforts. So, but the reality is just the actual experience of being through a deployment is a pretty psychologically jarring situation for a lot of folks. And I'm just going to share a little bit about my experience today. I'm not trying to get into big time war stories or anything like that, but just to demonstrate to you that just even the act of joining the military and some of the things that you do there, although it's, for me, it's been one of the most rewarding experiences, but as you look ahead potentially as people who might be providing any kind of care or treatment or anything like that, that if we just automatically sort of jump to PTSD as the main thing, which absolutely is, a condition that we treat, very difficult, just the experience of going on a deployment is a pretty huge ordeal. Just to give you an example. So here I am, relatively new in my career, not too smart about the military for the most part. As a matter of fact, at that point in time, kind of feeling like, hey, I'm a psychologist, kind of faking my way through the military at this point, trying to learn the culture, trying to learn the language of it, everything else. And, excuse me. So they end up one day coming in and they say, hey, we got a deployment coming up. And just be prepared, put it in the back of your mind, you're probably going to be on that deployment. Okay, fair enough. I signed on a dotted line. It pretty much figured, okay, this is a possibility, this could come up. Although when I joined, we were in peacetime, you never knew what was going to happen. But the events of 9/11, things started ramping up pretty quick. So, then I hear pretty quick afterwards, okay, yes, you are going on the deployment. It's probably going to be, we're looking at right now being signed up for a rotation. You're going to be going in about a year. All right. So, on the plus side, knowing a year out that you're going to be deploying gives you some time to prepare and that sort of thing. but it also gives you a lot of time to think about things. So, here I was, young family and everything, just not really, not fully established in other aspects of my career and trying to figure out how that was all going to work out. So then about a month later, I get another call. Never mind, you're not on the deployment anymore. Okay, well, okay, well. So you kind of go back into regular, civilian mode. And then about 2 weeks later, got a call again. Hey, remember that thing where we said you're not going? Well, actually you are again. That happened about 4 more times over the course of that year. All right, so this is even before you even get on the plane to go anywhere. So fast forward, I know I'm going on this deployment. I end up, they say, well, the psychology thing you got going on is pretty nice. It's pretty cool and everything, but it's not exactly what we're looking for. We need you to change your specialization. So we're going to need you to leave earlier than the deployment to go get re-specialized in another area. So, so we're going to sprinkle a little Army dust on you, change you into something different, move you along here. So that's exactly what happened. But now that year-long deployment now became 15, 16 months in there. So I'm not trying to paint a nasty picture here of the military. I'm not trying to dissuade anybody, but the experience sometimes that you go through, even before you get on the plane, it can be pretty jarring to your whole lifestyle. A lot of people we see at the VA now even, some of that trouble they have readjusting, the roots of it actually are much even earlier than the deployment, and then just sort of roll on through the deployment itself. Fast forward, everything's moving ahead, going through the training. Little things start happening, little things start changing. You get more involved with the what you're going to be doing. You get more involved with your training. They start sending you places to simulate a little bit more what you're going to be doing. So you're going out, in warmer climates, places like that. As the time gets closer, eventually they send you to Texas, and then they move you to Kuwait. You're moving into a situation where, the Army has sort of a, train as you fight mentality. So they're trying to prepare you, for what's going to happen. But as you're doing that, you're going through a process of, it's like with every step you take, you sort of lose a little bit of your civilian identity. And at first it's things like, okay, we don't have room to pack this anymore. Well, civilian clothes, they're gone now. After a while, you have less and less contact with your family. After a while, and you're slowly moving towards this whole process. Not to belabor this, but once again, this is all before you even step on the plane, so to speak. Day comes, it's time to move on now to, your duty station. In my case, it was Iraq. I knew I was going to be going all over Iraq, but we were going to, start off in Baghdad. We were there in Kuwait, and each morning, we wake up and they're like, okay, well, today's the day we're going to send you over there. Get all your equipment on, get all set and everything else. You get up there and they're like, it's been canceled for today. It's probably going to be, maybe tomorrow. You guys come back tomorrow, we'll see. So you unpack all your stuff, you kind of settle in for the night again. And you sort of go through this process until finally one day they're like, oh yeah, today is the day. We end up flying out. We're flying into Baghdad. As we're flying in, any Air Force people here? Prior Air Force? I don't know the term for it, but as we're coming in for a landing, when you think of a landing on a normal airstrip, it's kind of this nice gradual touchdown, that sort of thing. Well, apparently they had been taking some fire that day. So they said, and they sort of give a little warning, hey, we're going to do such and such maneuver to come in. And we didn't really know what they were talking about, but it's like, okay, well, that sounds good. The landing looked more like this, down into a much shorter area, to avoid, I guess, the surface area where you could be fired upon. And they go ahead and they explain that to you at the time. So you kind of have one of those oh crap moments. This is really real. This is really happening now. You go ahead, we land, we get marched in there. They put us sort of in our temporary housing. The first night we're there, we get a mortar attack. All right. For people who had been there before, one of the things you would notice is that the people who had been there before barely wake up. For those of us that were new, it was like every little sound was kind of like all right, what's going on with this? Fast forward, you finally become one of the people that's barely waking up for some of those experiences. You kind of like, you sort of learn to discern, kind of like when a thunderstorm's coming in, like when the thunder and the lightning, you know when it's moving away, you know it's coming in. Kind of in the same way, you sort of have the same experience with, munitions, things like that. So all of that to say, that adjustment that you go through, now that's not even a combat situation, but the sounds, the sights, everything that you experience that affects your senses. You can imagine, as psychology majors, you know what happens when our body becomes stressed, right? The cortisol kicks in, the body reacts, you get that fight or flight response in there. So you take your average individual, your average normal person, and you put them in these circumstances and you extend that over the course of a year. I don't care if you've never seen a day of combat in that whole experience, just the fact that you've been there and your body's had to adapt to that experience. When you come back, what's got to happen? You got to adapt back. All right? Now, I'm not saying all this to be dramatic. Not every deployment's the same. I could go on and on talking about this, but there's sort of the pre-time for the deployment. There's what happens during the deployment. And for a lot of folks, that also means going out into combat situations. And then there's what happens when you come back. I throw all that out there because, as clinicians, and as future clinicians, folks who are going to be working with some of these folks, you got to understand that when we talk about what happens to our veterans, we're talking about an extended period of time of dealing with various kinds of stressors. And then if on top of that they become traumatized in combat situations and battle, then in addition to that, you're also talking about PTSD symptoms. All right? So that's the end of my quasi-war stories for right now. But I throw that out there because you think about the opportunities that you have as clinicians to study, stress, what the impact it has on the body and everything else. So the military and psychology have had sort of this really unique relationship over the years. And there's a lot of things that a lot of the things you're studying right now, whether you're studying about the types of tests that we do, or if you're learning about intelligence or memory, whether you're talking about motivation, those real basic, foundational concepts that you get in like your Psych 101 courses and that sort of thing, there was this unique relationship that occurred between the military and psychology where a lot of the concepts that we use in psychology, the tests that we use, the intelligence tests, a lot of them were born out of the military. And a lot of times folks don't fully realize that. When you're processing sort of mass events, when you're trying to understand who's going to do well in battle, who's going to do well in a military situation, Stanford Binet, a lot of those tests that we use, a lot of them originated out of what was going on in the military at the time. So, kind of a little side story. Okay, in your psych courses here, who's heard of B.F. Skinner? Okay, quite a few of you. So, when the war efforts were ramping up, they looked to psychology, it's sort of going more into those applied stages, where they're trying to figure out how can we use this whole psychology thing to actually do something that's pretty useful here. So, B.F. Skinner, big name in the field at the time, behaviorism, all that. He gets some money, basically, they kind of lock the guy in the room, and they're like, okay, well, what can you do for the war effort? And he says, leave me alone for a while. So B.F. Skinner, hanging out, he's got his pigeons. Much like his rat experiments that he did, he also had pigeons that he worked with. All right. They leave him alone for a while, They come back, how's it going? I'm on to something here, just give me a chance. Time goes on. They end up moving forward. come to find, they come in and, they say, okay, what do you have for us? And he sets up this whole scenario, and he's got this pigeon that he starts flashing different dots in front of it, and it goes up and it pecks the red dot. The folks are like, okay, big deal. So you taught a pigeon how to peck a red dot. All right, so what's the point? Well, he was able to incorporate that into, at the time, one of the most advanced abilities to, on radar, detect the red dots that was on the back of planes on the tail of it. So pigeons have much greater visual acuity than human beings. So I'm not going to say that was one of the more illustrious moments in military history, but it's just kind of a, kind of a cute little story, about that. So psychology and the military have been linked, hand in hand since the beginning of time. The way that we fight battles, the strategies we use, the social psychology that's behind it, all of that can very much impact the peace efforts as well as the war efforts that, that go on there. So based on time, let me switch gears a little bit. Let's talk a little bit about, so how does somebody go into, working with veterans? How do you go into military, psychology in general? And I've heard a lot of people give really just bad information on this. So at the end of the day, any type of psychology that you go into, at the root of it, the psychology piece is probably the most important thing. So I have been a forensic psychologist, I've been a military psychologist, and you'll hear people talk about, well, you can go get the forensic piece first, and this, and you can go get the, go learn military sciences, do that sort of thing, and then you can work your way in there. It's not that those are necessarily bad routes to go, but hands down, the most direct route, if you're wanting to be a clinical provider, is to become a psychologist, or a social worker, or a counselor, or a psychiatrist. Those are pretty much your main routes to getting in there. And then once you have those degrees, then you have the ability to sort of specialize in there. So I say that because, and some folks will disagree with me on that. But I mean, as far as, one of the most direct routes to get there, if ultimately your goal is to be a clinician and do that kind of work, getting those clinical foundations first, the master's, the doctorate if you're willing and you're wanting to go on and doing that. So just some thoughts on that. So why don't we break this up a little bit? So what questions do you have about getting into these kinds of fields? It's a quiet room.
Okay, so you think it's more of a, not what you know, but who you know to get inside to?
No, I don't think it's so much a who you know. I think it's more about getting the foundations down, that you really need. Ultimately speaking, there is a huge crisis in Ohio when it comes to the amount of caregivers that we have. And that applies to psychiatrists, it applies to psychologists in particular. When you just break it down pound for pound, there's just not enough per county, for a lot of the services. Whether you're talking about military, whether you're talking about, in general, the number of folks that are going into the field. So when you get that degree, when you go on and you get that, the specialty part, it's much easier to sort of specialize after the fact. I would have never have thought of necessarily going into forensic psychology, for example. It wasn't where I was thinking about, in terms of my career or anything like that. But once I had that general clinician background, it was just like the opportunities just kind of present themselves, and then, you pretty much picked up what knowledge that you needed to. Of course, it's always good to network. If the more people you know in the field, the more opportunities that you're going to see when they come up. So, does that answer your question?
Yeah.
Okay.
Do you have to serve to be a military psychologist?
No. There are civilian psychologists who work directly with the military. It sort of varies just based on what's going on at the time, but Even where I work, we employ civilian psychologists to come in, and usually it's more like a contractual, type of relationship. I know that the Air Force does employ some civilian psychologists, and the roles vary. Sometimes it's more of serving like the families, of the soldiers. That's the flip side of all this. While the soldiers being deployed, the families, a lot of times in the back, and they need support too. So, yep. Yeah.
When you do serve and you go through like basic and AIT, do you have to do a certain amount of years before you can like be okay with being a military psychologist and being like cleared for it?
No, pretty much. Although most of the psychologists I work with do have some prior service time, we have some that come in directly. Basically, once you have that degree in hand, and the main thing is the clinical license. So once you have the license, whether you're an LISW or whether you're a psychologist, once you have that, you go through basic, you get direct commissioned, immediately right in. So.
For someone who is more interested in research as opposed to a clinician, what career pathway would you suggest for that?
Okay. In general or for the military?
For the military.
There are research psychologists that work in there, and we have people that we bring on a contract basis, as well as there's actually the MOS, or the duty title, of people that are research psychologists. And it's a pretty valuable part of what we do as well. Just as an example, we've conducted like 10-year studies of just a variety of different, mental conditions, problems that people are having. And out of that research, we always try to have an applied piece to it. So I'll just give you an example. Our research psychologists, 10-year longitudinal study, they were looking at PTSD, for example. And we noticed the prevalence of people who basically were more susceptible to trauma based on the fact that they had already previously been traumatized before the military. So what that did is, it didn't put us in a position where we were thinking, okay, we need to rule people out, of coming into the military if they've been traumatized. But in our screening process that we use for folks, we try to have a better understanding up front of if somebody has like a traumatic background, to make sure that we can sort of bolster them up, or make sure that we're being a little more preventative. So that career path, is a little bit different in that typically they're looking for somebody with like an industrial organizational background. Sometimes they'll take people with a social psychology. Typically you're still looking at doctoral level in a lot of cases, but they have a whole track for that. I think you had a question.
For somebody that wants to be a psychologist in the military, would you say that it would be better for them to get their doctoral degree first instead of joining as a bachelor at a bachelor's level?
If you join at the bachelor's level, there are opportunities. So like for example, during my most recent deployment in Kuwait, we sort of had like 2 layers of service. One layer of service was the clinicians. They all had to be doctoral level. We had also individuals who were in process, either getting their bachelor's, maybe working on their master's, and they were the ones doing the screenings. They actually, in the military, can do a surprising level of clinical work. More of it's like prevention-based, that sort of thing. So what I would say is, if your goal is to become a clinician and to be, paid, you're going to be an officer if you already have your doctoral degree. If you're wanting to, while you're working on your bachelor's, that sort of thing, you can come in as an enlisted soldier. They don't necessarily start you off at the beginning. A lot of times they'll give you some credit for your bachelor's that you're already working on or how much time you already have in school. You can come in and do certain tasks, typically under the supervision of a psychologist or an LISW. And some people like to go that route, because eventually, as soon as they finish the doctorate, then they get commissioned, then they'll make the jump to the officer ranks at that time. So there are opportunities if you're looking at the bachelor's and master's level. It just really depends on what you want to do. Okay. Any other questions? Sure.
When you were deployed, did they give you patients, or were you just part of like a troop?
Over the course of about the 18 years, the first part of my career, when I was with the PSYOP unit, I engaged psychology every day, but in a very different role. It was more of studying cultures. It was more of getting out and interacting with tribal leaders. There was a lot of social psychology involved in it. I never saw a patient during that whole deployment or anything else. When I said they sort of, repositioned me into a different kind of position, it was actually to do PSYOP work. So at one point in time, I had a break in my military career. I came into the National Guard, and I came in specifically as a psychologist treating soldiers, which is what I do now for the National Guard. So now we do a lot of, we work with some active duty, but we also work with reservists and National Guard. So we see a lot of folks. Obviously, there's only so much you can do on a weekend. It's because really, in essence, you're a part-time soldier at that point. So when I was deployed this last time, it was as a clinician. We ran a clinic, just like a regular 9 to 5, kind of position. People would come in. We're seeing a nice change go on where it's not so much that people are being assigned, but people are actually starting to approach mental health. Back in the day, almost every referral we got was a referral because, let's face it, a lot of folks are just a little too macho to come and see the mental health providers. Or there's, in the past, especially, there's been a lot of stigma. It's getting better. I'm not going to say it's great yet, but it's improved. But there's a psychology to that as well. To give the long-winded answer to your question here, like on this last deployment, what I really found is that when we approached soldiers, and we instead of just saying, okay, we're going to throw some mental health at you, we really tried to work with them where it hurt. Okay? If I come into a room like this and I say, okay, how many people here have had a mental illness before? You'll get a few people who kind of like sheepishly, and I'm not going to ask anyone to do that, by the way. If on the other hand, and I have no problem asking this question here, and I could ask this in a room full of soldiers, okay, how many people in here have normally get the recommended 7 to 8 hours of sleep a night? I might get a couple hands here and there, well, especially amongst students. Yeah. If I said to you, how many people in here get, so for just the purposes of this exercise right here, how many people here get 8 hours of sleep a night? Okay, so we got a few healthy individuals here, and now there's the rest of us. How many people will get 5 or 6 hours a night? Okay, we get a few more hands. How many people here get less than 5 hours a night? Okay, so I can go into a room like that. When we start working with soldiers, and basically we're saying, we got a sleep management program. That's a role for psychology. There's a lot of things that we can do to help out. We're not necessarily focusing on, the mental illness side of things. But what I find is that once they come in and we help them fix their sleep, they're much more open to saying, hey, this wasn't such a bad experience. Maybe I could talk to you a little bit about this other thing going on over here. So all of that to say, there's a lot that we can do. We don't think of like traditional mental health, but helping people with their health. So at the VA, I am a health psychologist. So all the work I do is around trying to get people healthy. I don't care if it's helping them manage their diabetes or helping them with hypertension or trying to help them get their sleep back on track. But I do a lot of that work in the military as well. It's getting people healthy again. So gone are the days when we always think about this as, here's the psychologist, here's your little zone of mental health. There is so much more that we do now in the overall health arena. So, yeah. Yeah.
Your first deployment, what were you expecting?
What was I expecting? I had no clue.
Were you expecting to treat patients, or were you expecting to do whatever they tell you to do?
At the time, I had had just enough time in the military to get indoctrinated in, enough to know that every military branch is a little bit different. And this is good, bad, or indifferent, however you want to describe it. When you think of Marines, there's a certain mentality you think about. When you think about the Army, there's a certain mentality you think about. When you think about the Air Force, I'll speak for the Army when I say, in the Army, you're a soldier first, and then you are your specialty after the fact. Some people will say that, like in the Air Force, you're typically your profession, and then you're an airman or whatever position that you're in. But in the Army, once they told me that I was going to go and do something else, I wasn't thinking so much like a psychologist at that point in time. It was pretty much, okay, how do I learn the job I have to do to get, go in there? So, and that was a unique experience I had. Most psychologists are going to go in and they're going to treat soldiers in there.
So I have a question. So you know how like they pre-train you to go off to war? Do they like pre-train you to like come back home and be like a normal civilian again?
That is the $1 million question right there. And that's a great question. Over time, that system has evolved a little bit, and it is really hit or miss. Here's the downside. And this isn't a hack on it, this isn't like a public service announcement for, how poorly some aspects go. But imagine your experience, you've just been through a year of X, plus pre-deployment, all that sort of thing. You come back to a base and they're sort of deprocessing you now to go back out. And you hear somebody in the wings over here saying, if you answer yes to any of those questions in mental health, you're going to get yourself a ticket to staying here for an extra 2 weeks or 3 weeks or whatever. You're going to get stuck here getting treatment. Go home, go hang out with my family, stick around here for another several weeks to get treatment. People lie, pretty much. Just to be blunt about it. So that system has really posed some challenges. As we've gotten a little more sophisticated about it, we've started looking at like 30 days out, 60 days out, 90 days out, doing screenings, doing things like that. Just to, we try to give the tools to the leadership so the leadership can kind of say, hey, you know what, this person, they're a little crispy after the deployment. They're not handling stress so well. They're not getting along with their family. So there are some things that are built into all of that. Sometimes there are some programs that are excellent. The challenge there always is in the military is when you are trying to apply something that's a good idea to a very large, incredibly diverse group of individuals. I'll give you an example. There was a program, my last time here in Kuwait. We want to make sure that everybody, has some kind of support to get a job when they get back. Okay, fair enough, sounds great. So they give you this 30-page packet of questions to fill out. You go through, and it's all very well-meaning to get you, so you can reintegrate back in. Now, a lot of you in the position you're in right now where you're sort of in a state of transition, you're trying to figure out the next steps, you probably look at this thing and think, okay, it's a little long, but okay, that's good. This is going to maybe point me in the right direction, maybe some jobs I hadn't thought about or whatever the case. Okay, been in the field of psychology, between everything I was doing before my doctorate and all that, for 25 plus years, and they're saying, we think that maybe you should look at the career of being a psychologist, based on the things I'm filling out. It's like, yeah, I know that, thank you. Kind of been there, done that, you got the idea. Okay, well, you filled out your packet, now you get to go see a counselor so they can talk to you about what it would take to be a psychologist. And I go in and I talk to somebody that is literally fresh out of college themselves and telling me how to become a psychologist. So there are some excellent efforts out there. They're trying to do the right things. It's little by little, we're getting closer to it. We're getting a little bit better at it. But once again, you're trying to apply concepts to a very massive group of very different individuals, some of whom are ready for retirement, some of them are brand new in their military career, that sort of thing. Not to mention the fact that When you're coming back, there's some people, they've been deployed before. They already know what to expect and everything. You have other people, just like I was on my first deployment, it's like you didn't know what to expect. You didn't know what to expect when you got back. So if you have any interest in it, and if you are interested in overall just learning more about like the psychology of deployments, that sort of thing, take down this name, the Center for Deployment Psychology. It is an excellent resource. They have great research out there just showing what actually happens when, you know, what happens to the family while the soldier's deployed? What happens to the soldier? How do you do little things to help them get connected back in? So it's one of his sole focuses, or foci, is getting you sort of reintegrated back in. And using good research to do it, not just, this sounds like a good idea, but so we're almost there, but there's some challenges. Yeah.
Is there a standard soldier to psychologist like ratio?
You know, I could see where ideally at some point in time we would get there, but right now when you look at just the overall numbers, it's so woefully low at this point in time in terms of what actually is there to offer for the actual like in-country, you know, when you're actually deployed. It would be a pretty tough measure at this point in time to figure out what even like peacetime versus, you know, wartime, you know, that sort of thing. I will say that it all depends on where you're at. I mean, if you're out in the, you know, sort of the backbrush of Afghanistan, you know, access to care might be a little bit different than if you were at like Kuwait, you know, or a place like that. So that's something we're constantly working on, trying to figure out. It's like, well, how many clinicians do we actually need? But it's kind of a moving target in that way. So, yep.
Are you ever at the front line?
What, was I ever at the front line?
Yeah.
Yeah.
To back up the psychologist.
Yeah. Yeah. It's been a big philosophical shift over the years in terms of how psychologists are really used, you know, when it comes to, you know, sort of being at the front lines or other places. You look back historically speaking, you go back to World War II, you go back, you know, even further than that, and the idea was if a soldier had shell shock or, you know, had any of those things, they would send them back to Germany, they would send them back somewhere else if it was like a severe case. If they weren't telling them just to buck up and go back out, you know, they would send them back. As you started getting more and more into Korea, in that area, you had psychologists sort of embedded in different places. As you got closer to like Persian Gulf War and, you know, pretty much everything after that, what you started seeing more is, let's take the assets to where the people are. So, and that was sort of in the heyday of sort of like the debriefing movements and that, where you have a crisis situation, you have people there to debrief people right after the fact. Depending on who you talk to, some people will say that it's a good idea or it's a bad idea, but all of that really shifted psychology and social work so that we would spend some time, like just an example, this last deployment, we had sort of a home base in Kuwait, but then we were going out to various countries, pretty much all over the whole theater of operations. So we'd spend some time in Iraq, we would spend some time in Afghanistan, we would float around depending on where the greatest need was. There's also what's called combat stress teams, and those teams, they are very mobile, and that becomes their main job, is to sort of mobilize around. So, yeah.
So somebody who is in treatment from like the first round that they went through, and they're like still in treatment, and they go for like a second round, is there like treatment available so they like don't get worse?
So that's handled a couple different ways. One is, if a person is on a what's called a profile. So let's say you're in and you have a physical condition, you hurt your leg, hurt your, you know, or if you have a mental condition, you know, it's been shown that you have PTSD, depression, anxiety, whatever the case. You can go on profile, and as a clinician, I have the ability to say, okay, is this person deployable? Now, certain conditions make you non-deployable, period. And then there's some that are sort of in the gray area. So just as an example, okay, typically speaking, in what you've learned and everything, when do people start typically showing signs of schizophrenia?
22-ish.
Right. So if you're looking at early 20s, mid 20s, that sort of thing, when do people tend to join the military? Typically right out of high school. So it's not an uncommon phenomenon to have people come in and then they're doing fine at first, but then some of the symptoms start to pop up of schizophrenia. Then we need to look at, okay, is this person going to be somebody is it going to be the best case scenario for them? Are they going to be able to get treatment if they're, the kind of treatment they're going to need if they're deployed, just as an example. On the other hand, we also, you ask actually a very complicated question because, no, it's a good question. It's one that we struggle with because there are some individuals that they'll come back from a deployment and it's not an uncommon phenomenon where it's like, you know what, I felt great when I was over there. It's like I felt like I was serving my country, I was doing these great things, I felt like I had a purpose. I come back and school's not going so well. I'm working at Walmart. Not that there's anything wrong with working at Walmart, but it's like I'm being told what to do by a supervisor who I think is a jerk. Or I was over here and I was leading, even in the, some of the lower ranks, you get leadership opportunities. So it's like I had this job over here where I felt really good, So I want to go back, and you'll get people that will become just deployment after deployment after deployment. That can be a good thing, but the downside of that is one of the things that we know from the research is that deployments have a cumulative effect. So if you got PTSD the first round, PTSD symptoms, just because you have a better time when you're over there, you're basically just adding on each time. Same thing with anxiety, same thing with depression. So you see a cumulative effect. So ultimately, whereas the person might be using it for a certain amount of escape, eventually they got to come home. Mm-hmm. And every time they do, they're coming back a little bit worse off. So there's no short answer to it, because if you came to me as a soldier and you have anxiety, well, it's like we can treat your anxiety, and even when you get deployed, we can probably still continue to treat the anxiety. But when does the anxiety become so bad then that it's no longer doing you any good to be there in that? So that's one of our roles too, is to advocate sometimes and say, this is just a really bad idea for this soldier to go back in that way. Which, depending on, if you got a leader and that was one of their go-to people, they may like that idea or not like that idea in there. So there's some advocacy in our role, that we do in that way. So certain medications automatically put you on hold for deployment as well. So if you are taking any psychotropic medication that you take, there's an automatic 90-day period where they want to make sure you're not having any major side effects before they send you off on a deployment. So it kind of stops you in your place in that way. But it's not a disqualifier from you doing things, but just depending on your specific scenario, you may get moved forward, you might not. So, please.
You mentioned stigma earlier.
Yeah.
Can you share with us some suggestions or things to think about when we leave this room to help reduce stigma in general and also for soldiers, veterans?
For me, I think one of the strongest things that we can do to reduce stigma is stop treating mental health like it's in a bubble. One of the things I love about working in primary care is I'm not thinking about a person in terms of their mental illness. I'm thinking about their overall health. When I'm doing an assessment with somebody, it's like I'm looking at their intellectual health, their spiritual health, their mental health, their physical health. How well they're able to relax, recharge their batteries. When you start couching it that way, then it's not such a stretch then to say, hey, how are you handling your stress? How are you handling things? Is that an area where you need a little bit more help? And after you've established that relationship within the context of overall bigger health issues, most people are a lot less resistant in that way, as opposed to, what we've done in the past a lot of times in mental health was, we call it mental health, but really what we've been treating is mental illness. So I think actually taking the health side of things, a lot of the things we do in positive psychology, it's just a huge potential for us to really look at what does it take for a person to be mentally healthy. We wouldn't do that with a diabetic, right? I mean, if you had a diabetic who came in here and you were their primary care doc, you wouldn't just say, okay, well, here's your pills, here's your shots, you check your, if we did that, we'd be a pretty lousy doc, right? We would be looking at how do we improve your lifestyle? How do we help your overall health? If we get your health good enough, maybe it'll reduce your need for medications, or maybe it'll reduce your need for things. You're looking at the bigger picture. Why are we not doing the same thing in mental health? I think that's the biggest way that we can really impact stigma in that way. Help people get so much more mentally healthy that they're just better able just to work on their mental illness. So, does that answer your question?
It does, and a lot of students in the room are in intro to psych right now. And so maybe not just mental health stuff yet.
Yeah.
When you mentioned Skinner, that's today and next time for me.
Yeah.
But just kind of like a couple strategies even. What can we do in our personal life to be more open and understanding, I guess?
Well, I think a lot of it, so as a lot of you move forward, like when you start taking those classes where they start talking about mental illnesses and that sort of thing, when I used to teach a lot of these courses, one of the things it was almost kind of you'd kind of laugh about it. And I remember doing it myself when I was in, like abnormal psych and some of those classes that you get into. As they're describing the conditions, you can look at almost every one of them and go, hey, I kind of got some of that going on. So normalizing the human experience. We're all on kind of a spectrum of where we're at with a lot of these conditions. So having open conversations with folks and letting them know, hey, you know what, a lot of the things, a lot of us sort of have that private life within ourselves, and we assume that the thoughts we have are so much more weird than what everybody else is having, or that we're looking at things maybe a little bit, differently or whatever the case. But the fact of the matter is we're all a little bit weird on the inside, So normalizing the experience, I think that's a big one. If you see somebody that's having some difficulties, just engaging them. I've always been a real big fan of what's called, psychological first aid. And that's something that all of us, can do. And what I mean by psychological first aid is, it's like when you encounter somebody that's in crisis, helping them deal with the basics, like getting them connected to the right individuals, making sure that, helping them make that contact to a family member or somebody else that they trust, because when they become disconnected and all that, not every one of us has to necessarily do psychotherapy with all of these individuals. Obviously, a lot of you are going into this because you do want to help people out. Sometimes the biggest help you can give is sort of that first, if you're the first person that's dealing with somebody who's going through a crisis, making sure the basics are covered. Are they sleeping okay? Are they eating okay? Are they getting, if they need to talk to somebody? Sometimes it's, if you're depressed, it's a hard thing to go through the process of trying to find a clinician in that way. So making that call for them, that sort of thing. So, it's not earth-shattering kinds of things, but helping people with those basics, helping them sort of get connected in, making sure that they're just even sort of taking care of themselves in that way. So, and keep in mind, a lot of these things we learn while we're sort of in this environment. You learn a little bit about stress management, right? You learn a little bit about some of these other things. Think about a lot of the people that that maybe are not fortunate enough to be in like an environment like this. Some of those skills that we take for granted in terms of like stress management, not everybody gets that stuff. So point them in the right direction. Any other questions?
Can you repeat the source for more information?
The Center for Deployment Psychology.
Thank you.
Mm-hmm.
time for people to get to class.
Yeah,
Yes.
yeah. And I can stick around for a few minutes if you have any specific questions, but thank you for coming. Appreciate it.